Good morning, Jay. Good morning to everyone. A pleasant Tuesday morning po sa inyong lahat. Marami po tayong viewers ngayon. May mga nasa Ohio, nasa Canada, nasa Pilipinas, and maraming salamat po for sharing your precious time with us for you to be able to learn on circulatory shock topic. So this topic will be provided or will be discussed today by our NCLEX educator, Sir J. Padong. So sorry to everyone. I think we started late. Nag-conflict yung
It was
hindi
quick.
na-coincide yung ano namin, yung napag-usapan na oras.
Supposed to be like 9 p.m. I was thinking about 9 p.m. in the Philippines, like and 7 a.m. here in the US. But well, ano pala siya? 7 a.m. pala sa, 9 a.m. pala sa Pilipinas and 7 a.m. 7 p.m. dito. See, I'm kind of confused about the time already, but well, that's the thing about the time differential between us, pati sa Pilipinas. Well, anyway, so that was a quick preparation though. It's supposed to be tomorrow, but yeah, we'll go kasi may naghihintay sa atin, right?
Yes,
so I cannot see the I can only see the participants here, the two of us. So most likely in Facebook, di ba no?
Yes, we are live in
Facebook. Okay, that's why because
and we are also live in IPASS NCLEX because I shared it in IPASS NCLEX. And we have 186 viewers.
Oh, that's a lot.
So yes, that's a lot. And guys, you have to prepare for your pen and your notebook because we are going to talk a lot today. And Jay, how many hours are we going to today for this discussion?
I'm not sure. I can talk about everything under the sun.
Okay, guys.
It's circulatory shock, but I'll make it like as brief as possible. We'll minimize our time. Let's just say optimize our time in maximize learning. You know what I mean? Like dapat kahit konti lang yung time pero marami tayong natututunan. Okay, so I'll go with the principle. In that case, I'll go with the principle, not the detailed thing about a circulatory shock. So I always go with the principle. Everybody knows that about sa mga IPASSers natin sa online academy. So I don't really go into details as in because for me the most important is the foundation, is the principle talaga. So I just want you to know, you understand the what circulatory shock and what are the types of shock included in that specific concepts. Okay.
Okay, guys, just a very brief introduction about Sir J. So Sir J is one of our expert NCLEX educators in our IPASS Online Review and Mentoring Academy. He has been teaching nursing for so long. How many years already, Jay? More than 10 years almost.
I guess more than 10 kasi I've been a nurse for 18 years eh. No, it's not 18 years. It's 19 years.
Mm-hmm.
So more than half of it are like from the education. Even now, I'm on the field. I'm hands-on. I'm on the bedside, and at the same time, I'm doing teaching. So it's some kind of the education is kind of dragging me to. Kumbaga, dinadrag ako parati ng ng education, ng passion to to share my experience.
So here in the Philippines, Sir J. Padong was previously a clinical instructor in one of the known schools here in Davao City, and currently he is working in Texas as a nurse, and also he's been working as a charge nurse as well in their hospital. So I will give to you to Sir J to discuss your topic on your NCLEX. So over to you, Jay. Thank you very much.
Yeah, thank you, Shell. Thank you. And let me see the Facebook kasi I can't see if ever there's a question. So I needed to see what's your questions, right? So kailangan ko i-open yung Facebook ko, guys. I'm sorry. Seems like parang hindi ako ready, but well, this is always a battle. Life is always a battle. You don't know what's going on. So asa na yun? Bakit nawala ang live IPASS processing, right? So
Yes.
just hold on a second, please. Oh, ang dami nating viewers.
Yes, we have 230 viewers.
Isa-silent ko na lang siguro para hindi mag-feedback. There you go. Ayun, Miss Charity. Nakikita ko kagad ng name. Miss Charity, Teen Joy. Oh, Teen Joy is also from online review natin. I'm not sure. Vince is also here. Vince is our coordinator. Who else? Marami pa sigurong iba. JR, Givero, a lot. I cannot shout out one by one. But hello to you guys. Good morning in the Philippines. No, yeah, good morning in the Philippines. Good evening here in the US. Also in Canada, good evening. And good morning din sa Australia. Good afternoon, I guess, in, I'm not sure. I'm not really sure in Middle East. It's parang yata medyo ano pa, maaga pa sa ano, super early pa sa Middle East.
Yes.
All right, so let me share my screen. Mabilisan lang to siya na ano, na discussion. Let's see. Saan tayo dadalhin ang ating discussion today? Our discussion today is about circulatory shock. So it's a big topic in NCLEX. Alam mo naman natin that we have different types of shock. Hold on. Hold on kasi may ano, i-warning ko lang sila kasi may hold on.
So while waiting for Sir Jay, yun.
I'm here.
Okay.
I'm here kasi I need to warn them kasi sabi ko may lecture ako. They didn't know na may lecture ako kasi usually morning talaga eh. But anyway, so yeah, our discussion for today is circulatory shock. So I hope you will learn something today na dadalhin nyo sa inyong NCLEX. By the way, MJ Padong, I'm working here in the US, like Miss Rachel said, here in Baptist Hospitals. Here in Texas, Beaumont, Texas. It's near Houston. I've been a nurse, like I said, for 18 years. More than half of them are in the education. Right now, it's a combination of both. I'm on bedside on a medical surgical unit. It's a very active floor, and I was a clinical instructor before in the Philippines in Davao. I was also a nurse in ICU. That's my very first experience. And in Saudi Arabia, I was also working there for like 4 years, and then coming back to the Philippines, do the review again, physical review in IPASS, and then here in the US nakaagad. So all in all, I have like 18 years experience as a nurse, no non-stop nursing experience. But anyway, so tawag niyan. So I'll be here to discuss about circulatory shock. Okay. The first thing that you have to look at when your patient is having shock, or let's just say, anong pinaka-importanting vital signs? Anong pinaka-importanting vital signs that you need to know if you're thinking about shock? Or let's just say, for example, if your patient is having these vital signs, anong pumapasok sa isip mo? Let's go with the critical thinking, with the clinical reasoning. Actually, sinasabi ko na yung answer. Okay, so if you have, for example, tingnan ko ang answer ninyo. Pa-shoutout daw po daw. Okay. All right. 4 a.m. pala sa Saudi Arabia. Okay. Walang nag-a-answer natin dito. Okay. If you have low blood pressure. Okay. Anong iniisip natin? Ayan naman tayo si hypotakitaki. Hindi po lahat ng shock hypotakitaki. Justify natin yun mamaya. Okay? So baka malin lang tayo sa hypotakitaki na yan. I don't want that. All right. So blood pressure, low blood pressure, you think about shock. The question is, what kind of shock? All right? Pumapasok sa isip natin parati ang anong klaseng shock. Can I see your answers? Blood pressure daw. Hypotension. Anong klaseng shock ang pumapasok sa isip natin? What kinds of shock are the usual? You know, what are the types of shock that we always see? Okay, walang uma-answer? Can I see your participation, guys? Okay, we have your what? Hypovolemic. Yan, parati talaga yan, no? Hypovolemic shock. Hold on. Hypovolemic shock. Hypovolemic shock.
Jay, I think you were able to share your screen.
Here? Okay, let me share my screen then. Hold on. Okay, your hypovolemic. Can you see my screen now? Can you see my screen? Hypovolemic shock. All right. What else? Ayun, lumalabas na yung screen ko. Your hypovolemic shock. What else? What else? Your cardiogenic shock. What else? Cardiogenic, your septic shock. All right, we'll categorize it as your distributive shock. We'll justify that later on. Why is it called distributive shock? Your distributive shock is categorized into what? Number one, like you said, is your septic shock. What else? Distributive shock, what else? Septic shock, anaphylactic shock. Very good. You are participating. Anaphylactic and your septic shock, what else? Ano pa yung isa na tinitingnan natin? Hemolytic shock, what else? Septic shock, anaphylactic. What else? Ano pa yung isa? Hinahanap natin. What kind of shock is that? Your cardiogenic, hypovolemic. Alright? Nalagay na ba natin yung cardiogenic? Lagay natin dito si obstructive shock. Okay? Your obstructive shock. Most commonly caused by your pulmonary embolism, pulmonary hypertension, tension pneumothorax as one, and as well as your pulmonary hypertension. Yan yung mga cause ng obstructive shock natin. What else? Neurogenic shock. Very good. Neurogenic shock. Ayan, si neurogenic shock. Ayan, these are the categories of your shock. Alright? Or the types of your shock. Circulatory shock. Pag sinabi mong circulatory shock, it affects your circulatory system. And what does it mean? It affects specifically your what? Your cardiovascular system, your blood, and as well as your blood vessels. I mean, your blood vessels at the same time, your heart. That's why it's called a cardiovascular system. Your blood vessels, at the same time, your heart. Let's go to the basics, all right? So that we can explain one by one, all right? So your obstructive shock, your hypovolemic shock, your cardiogenic shock, and your distributive shock. Let's go to the basics first. Let's go to the principles. Let's go to the concepts, okay, that are behind this, these types of shock. All right? It justify, like I said, we'll justify what is distributive shock pagdating sa illustration natin. All right? So anong ibig sabihin? Bakit siya distributive shock? Bakit siya cardiogenic? Bakit hypovolemic? And bakit obstructive? All right. So like I said, talking about blood pressure. How far are you in understanding your blood pressure? Ayun. Saan ba nanggagaling ang systolic blood pressure? Saan ba nanggagaling ang inyong diastolic blood pressure? Diyan tayo magkakaproblema if you don't know what systemic vascular resistance, what is cardiac output, what is stroke volume, what is contractility, what is preload, what is MAP, those kinds of things we need to understand. Okay? So, I'm gonna write here your blood pressure. Ayan. Nakahan ko konti ha. Ayan si blood pressure. Okay? So, what are what are the principles behind your blood pressure in terms of, in the context of your anatomy and physiology, specifically your physiology? I'm gonna write here systolic blood pressure, and I'm gonna write here your diastolic blood pressure. Okay, your diastolic blood pressure. Okay, so your systolic blood pressure is coming from where? Your systolic blood pressure is coming from, since we're talking about what? Since we're talking about cardiovascular system. So two organ system if you think about it. Okay, your heart, at the same time your blood vessel. Your systolic blood pressure is specifically coming from your heart. Okay, so ibig sabihin yan, this is talking about your cardiac output. Okay, your cardiac output is actually equal to your MAP. All right, your cardiac output is, how do you quantify your cardiac output, by the way? How do you determine your cardiac output? Okay, how do you determine your cardiac output, by the way? Ayun, may nag-answer ba dito? Okay, your cardiac output is determined through what? Through your, ano nga yun? Your heart rate. At the same time, your, ano nga yung isa? Your heart rate at the same time your, ano yung isang ano natin dito? Your stroke volume. All right? You multiply your heart rate and your stroke volume, you can come up with your cardiac output. Your stroke volume is actually determined also by what? Your preload and as well as your contractility. Okay? Your contractility. Ganyan po ang ating cardiac output. Again, your cardiac output, if you define it or you describe it technically, like, technically speaking, how do you define your cardiac output? Your cardiac output is the amount of blood circulated in 1 full minute. And it's determined through what? In 1 full minute, determined through your heart rate, at the same time your stroke volume. Pag sinabi mong stroke volume, it's also determined by preload, which is the stretching, the amount of stretch of your myocardium to accommodate blood volume. Ibig sabihin, when you say like preload, you are talking about volume. Okay, I'm gonna make it red. You are talking about volume. That's your preload. All right. Again, when you talk about preload, you're talking about blood volume. Okay, like I said, your stroke volume is determined through your preload, at the same time your contractility. Pag sinabi mong contractility, it's, your muscles should work in terms of ejecting your blood. That's your contractility. In order for you to produce your stroke volume, which contributes to your cardiac output, you multiply it with your heart rate. That contributes, again, all in all, cardiac output. Pag sinabing contractility, you are talking about the heart function itself in terms of contraction. Madali lang. So this is talking about the heart. The heart itself, the heart muscles. Okay? So what about your blood pressure is also determined. Lagay natin dito si times. All right? Your watts, your diastolic blood pressure, cardiac output times your systemic vascular resistance. All right, lagay natin si systemic vascular resistance dito. Systemic vascular resistance. Ito matawag, hold on. Sorry guys. Lagay natin si systemic vascular resistance dito. From the word itself, systemic vascular resistance. Anong ibig sabihin nito? Systemic vascular resistance is talking about your blood vessels. Sulat natin si blood vessels dito. All right, this is your blood vessels. Ayan. Blood vessels. Ayan, ayan siya. We have the lining of your blood vessels, which is made up of your endothelial cells. Endothelial cells po yan siya. Okay? And we have, what makes your, itong tanong ko, what makes your blood vessels constrict or, constrict or vasodilate? It's because of the innervation of your what? Of the innervation of your nervous system. All right? Let's take a look at the nervous system first. The nervous system is basically categorized into two. Number one is your central nervous system. This is just an overview, guys. And we also have your peripheral nervous system. Your central nervous system is made up of your brain and spinal cord. Okay? Once it leaves your CNS, it's now called as your peripheral nervous system. All right? Peripheral nervous system. So your peripheral nervous system is made up of what? Your somatic, which is your voluntary, and as well as what? And as well as your autonomic. Autonomic. Okay? Your autonomic nervous system is made up of two branches of nerves, which is your what? Your sympathetic nervous system and your parasympathetic nervous system. Okay? These nerves, from the word itself, nerves, this will innervate your blood vessels. Okay? One of them is your blood vessel. Again, this is a network of nerves that innervates your organ system in your body. Including them is your blood vessels, including your heart as well. Again, innervate, it means to say nerves coming from your sympathetic or your parasympathetic nervous system. So when I draw like this, that's a nerve. All right? So this sympathetic nervous system innervates your blood vessel. Ito yung nerve natin. It releases certain chemicals. All right? After your action potential, after your sodium, after your calcium goes in, that's the time that your nerve, the terminal end of your nerve produces your neurotransmitters. And that's what we call as your norepinephrine. If you talk about your, SNS or your sympathetic nervous system. Okay? So what's the effect of your SNS, of your norepinephrine, which binds to your specific receptors? What receptors are those? We call them as your beta. What receptors? We call them as your alpha receptors in your, in alpha 1 receptors in your blood vessels and beta 1 receptors in your heart. Okay, so again, we're talking about blood vessels here. Now, if this norepinephrine binds to your what? To your alpha receptors, what happens? It causes what? It causes constriction. All right? It causes constriction by what? Constriction. Ayan, si constriction. Or vasospasm. All right? Vasospasm. Okay? That increases your vascular resistance. That increases your blood pressure. Okay, again, your sympathetic nervous system. This is the nerve. It releases norepinephrine and it binds to your alpha-1 receptors. After binding to your alpha-1 receptors, what's the effect? It causes constriction, or also known as your vasoconstriction. Vasospasm that causes increase in your vascular resistance, increasing your blood pressure. All right? That's your systemic vascular resistance in terms of sympathetic nerve activity. On the other hand, what's the opposite? Ayan, si versus. Your PNS, ayan, innervates also your blood vessels. Okay? It releases acetylcholine. Ayan, si acetylcholine. Your acetylcholine, all right, your acetylcholine binds to your specific receptors, your M receptors right here. Ayan, it will bind to your M receptors. What's the effect? It causes dilation. All right, causes dilation. So dilation causes relaxation. I mean, by relaxation, decreases your blood pressure. In other words, decreases your systemic vascular resistance. That's just a sort of review. All right? Dalawa lang po ang klase ng nervous system. Your central nervous system and your peripheral nervous system. Again, when you say like central nervous system, brain and spinal cord. When it leaves your brain and spinal cord, it's now becoming your peripheral nervous system. There are two branches, your autonomic, which is involuntary, and your somatic. Your autonomic is your involuntary. Okay, and there are two branches, as we all know, very famous. You know what? If you just know, if you just memorize, not just memorize, if you just understand what is autonomic, your sympathetic and your parasympathetic, as long as you memorize this, as long as you understand this, like I always say, actually, there's a lot of takeaways on this kind of concept. Okay, so well, again, your sympathetic nervous system innervates your blood vessel, because we're talking about vascular resistance. All right, this innervation, these nerves causes the release of your norepinephrine. Okay, norepinephrine, or also known as your noradrenaline. It binds to your alpha-1 receptors in your blood vessels, causing systemic vascular resistance increased. On the other hand, the opposite is parasympathetic. Okay, the parasympathetic releases your cholinergic, your acetylcholine. It binds to your M receptors or muscarinic receptors. It causes dilation by relaxing your muscles of your blood vessels, causing decreased systemic vascular resistance, decreasing your blood pressure. That is your systemic vascular resistance. Now, if you talk about your SVP, you're simply talking about your heart. Okay, you're simply talking about your heart. If you talk about your diastolic blood pressure, what did I talk about? Talking about your blood vessels. All right? Talking about your blood vessels. Lagyan natin ang emphasis dito. Talking about your blood vessels. So we categorize this blood pressure into two, right? I'm gonna put a line here. Okay? Ayan. So nakategorize na natin sila accordingly. Systolic blood pressure and diastolic blood pressure. All right, let's move on to our types of shock. When you talk about volume, ayan si volume, oh, it's talking about preload. All right, it's talking about preload. Something to do with volume. In other words, what kind of shock are we talking about here? Ayan na siya. What kind of shock are we talking about here? If we're talking about preload or the volume. Okay, this is talking about your hypovolemic shock. Okay? Hypovolemic shock. Yan, si hypovolemic shock. Okay, erase na lang natin si shock. All right. If you're talking about contractility, what kind of shock are we talking about here? This is talking about the heart contractility. The heart is not able to pump. That's the ultimate function of your heart, is to pump, relax, to distribute blood in a form of your cardiac output. So if you're talking about problems in your contractility, in your heart, what are you talking about? What kind of shock are you talking about here? It's your cardiogenic shock. Very good. It's your cardiogenic shock. Ayan. So what about in your diastolic blood pressure? Now you are talking about your blood vessel. You are talking about your blood vessel. This is something to do with your distributive shock. All right? That's something to do with your blood vessel. And number one is your septic shock. Okay, that's your septic shock. On the other hand, we also have your anaphylactic shock. And at the same time, your neurogenic shock. Neurogenic shock. Ayan. Okay, that's your distributive shock. Okay. For example, let's take a look at the example, septic shock. Let's gonna draw a blood vessel here again. Ayan si blood vessel. Okay. Okay, this is normally your blood vessel. It's composed of your endothelial lining. All right. Endothelial cells that lines. Again, it dilates and it constricts. When it dilates, it means to say it causes also increased permeability. All right. If you have, for example, an antigenic material in your system, for example, bacteremia. If you already have bacteremia, chances are you will have a lot of what? A lot of inflammatory chemicals. It's actually an exaggerated inflammatory response, right? Talk about sepsis now. All right. If you have these chemicals going on, there's a lot of chemicals in here. One of them is your nitric oxide, interleukins, histamines, prostaglandins. Ang daming ano, di ba? There are two pathways, your lipo-oxygenase pathways and your cyclooxygenase pathways. This causes chemical production that causes increase in the permeability of your blood vessel. Okay? It will cause dilation. By what? By increasing the diameter of your blood vessel. Magda-dilate po yan siya. Again, like I said, if this is your blood vessel, it will dilate. If it dilates, it becomes leaky. Ayan, it becomes leaky because of those chemicals. Number one is your nitric oxide. Ang dami pong pathways ng ating, inflammatory pathways. Okay, brought about by an inflammatory response. Okay, these chemicals causes increased leakiness of your blood vessels. What's gonna happen? Fluids will what? Fluids will leak out. At the same time, do you think you will have a good vascular resistance if it dilates? No. All right. Ang sinabi ko dito, constriction is more on increased blood pressure, increase in your vascular resistance. Pag sinabing dilation, decrease blood pressure by decreasing your vascular resistance. All right. Dinadilate po niya. That's because of your inflammatory mediators. That's because of your inflammatory, chemicals. All right. What about your anaphylactic shock? The same thing. These are all talking about your blood vessel. All right. Again, draw na naman tayo ng blood vessel. It's the same thing. Primarily because of your histamine. All right. Histamine causes increase in your permeability by dilating your blood vessel. Anaphylactic shock is the severe form of your allergy. Remember that, right? So, ayan. Nagbabasodilate siya, causing leakiness. Again, causing decreased vascular resistance. Again, this is something to do with your blood vessels. Naiintindihan. What about your neurogenic shock? Your neurogenic shock. Ayan. Your neurogenic shock from the word itself, neuro, something to do with the neuro, the neuro system, something to do with a trauma, all right, with a trauma. For example, your spinal cord injury. Actually, neurogenic shock it's an emergency situation related to your what? Related to your spinal trauma, spinal cord trauma. All right, if this is traumatized, for example, if this is injured, your spinal cord, okay, remember, your CNS and your PNS are associated by way of your sensory nerves and your motor nerves. Diba? They send information and through the sensory nerve to the PNS, and the PNS sends information through your what? Through your CNS, through your motor nerves as well. Okay? So baliktad to. Dapat ito sensory and this one is motor. Okay? So they are associated with each other through what? They communicate to each other through your sensory nerves and your motor nerves. Once this is already injured, for example, what happens to your sympathetic nerves and your parasympathetic nerve? All right. Basically, when you say neurogenic shock, this is the loss of sympathetic tone. That's how you describe it. That's how you define it. Loss of sympathetic tone. Loss of sympathetic tone. If you lost this sympathetic tone, do you think you will have a good vascular resistance? No. All right, so that will affect your blood pressure. That will affect your vascular resistance. That will affect the dilation and the constriction of your blood vessels if you are injured, because again, there is loss of sympathetic tone. There is no tone of your sympathetic innervation to your blood vessels, causing what? Decreased vascular resistance. That's why you can have like low blood pressure, because you lost this. Okay? So all in all, this will all cause your what? Your low blood pressure. Okay, let's take a look at this. Why it's called distributive shock? It's because if you take a look at my my illustration here, all of them causes vasodilation. All of them causes vasodilation. Here vasodilated, here vasodilated. That's why it causes low blood pressure. This is vasodilated as well. The more it's vasodilated, the more it's permeable. The more your fluids are distributed outside your blood vessel. Okay, that's why it's called distributive shock. Okay, distributive. Walang loss of blood, just like in your hypovolemia. Okay, the problem here is in your blood vessel. The fluids are distributed. It's supposed to be in your blood vessel that gives you blood pressure, that gives you systemic vascular resistance. But the thing is, it's distributed from your blood vessel and into your interstitium. Okay, this is your interstitium, guys. Okay, so why? Ang question ko is that all the circulatory shock causes hypoxia. All right, all the circulatory shock causes hypoxia. Let's go back to this one. Hypovolemia, it's very understandable. If you have loss of volume, kung naubusan ka ng blood, natural wala ka talagang mabibigay na sufficient na perfusion to the tissues. Of course, natural magiging hypoxic ka. All right? The same way as your cardiogenic shock. As long as you have pump failure already, kulang ang binibigay na oxygen, kulang ang binibigay na sugar to form ATP. Alam naman natin, when you form ATP, you need your sugar, and also you also need your what? Your oxygen. All right? To form ATP. That's Krebs cycle, but I'm not going to talk about Krebs cycle here. All right? So, well, that's oxygen, at the same time your sugar to form ATP. Alam naman natin, ang ATP is the energy of your cell in any living tissues. Okay? In the same way here, what happens if you have septic shock? Increased permeability. The fluids are leaking out here in the interstitium. These are your tissues, guys. This will represent also anaphylactic shock and your neurogenic shock, this illustration. These are your tissues here. If your tissues are surrounded with fluids, do you think your oxygen that needs to go there can diffuse well? No, because of the fluids surrounding the interstitium. That's why you can have your hypoxia. Understood? All right. The same way as in your anaphylactic shock and neurogenic shock. And remember, this is not only talking about a specific organ in your body. This is talking about every blood vessels in your body. That's why it's called like circulatory shock, because it involves everything, every blood vessels in your body. Okay? And every blood vessels in your body involves every tissues also in your body. Okay? That will cause, every one of them will cause hypoxia. Okay? Let's go back to your hypovolemia, guys. Are you still with me? Shout out muna tayo. Okay. So hypovolemic shock tayo. So hypovolemic shock are caused by what? Alam naman natin, hypovolemia are caused by what? Your D. This is your dehydration. All right? Dehydration, not so fancy mnemonic, but at least to remember. Your excessive diuresis. All right? Diuresis, what else? Dehydration, I would say like, lagay na lang natin dito si decrease blood volume. Decrease blood volume. All right? In other words, bleeding. All right? In other words, that's bleeding. Okay? Dehydration may be because of diarrhea. Okay? Diarrhea. And as well as your nausea, vomiting. Okay? This is your DDDs. That causes your hypovolemic shock. Okay? This is again talking about, going back to your what? Talking about your preload, talking about your volume. Okay? On the other hand, lagay natin dito si obstructive shock. Okay. The obstructive shock is caused by what? Is caused by your pulmonary embolism, your tension pneumothorax, and as well as your pulmonary hypertension. Ayan, lagyan natin dito si tamponade, your cardiac tamponade as well. Okay, these four can cause decreased preload. Your pulmonary embolism, your tension pneumothorax, for example, your pulmonary hypertension, and as well as your cardiac tamponade. Okay, these four, mechanisms, these four conditions causes decrease in your preload, just like in your hypovolemic shock. So obstructive shock belongs to your preload, here category. Okay? Pag sinabi mong contractility cardiogenic shock, this is usually caused by which specific condition? Caused by your CHF, and most of the time it's caused by MI. Okay? If you think about it, CHF versus cardiogenic shock, if you think about it, it's actually the same because CHF is pump failure. Cardiogenic shock is also pump failure, severe form of pump failure. Nawala na talagang that causes really like, low blood pressure. Remember, we all started with your blood pressure. Every one of them will have low blood pressure. Okay, your CHF, not all the time they have the low blood pressure until such time that they have cardiogenic shock. That's the time that you can say that this is already cardiogenic shock. In other words, cardiogenic shock is a severe form of your CHF. Okay, and also it can be caused by your your MI, the famous MI, your myocardial infarction, acute coronary syndrome. Okay, in fact, that's the most common cause of your cardiogenic shock, causing low blood pressure. Ayan, pasok siya sa low blood pressure, pasok siya sa circulatory shock natin. Okay? Alam naman natin, ang septic shock is brought about by profound infection. Alam naman natin, ang anaphylactic shock is brought about by severe allergic reaction. And neurogenic shock is brought about by your spinal cord injury. It's an emergency. It's an emergency complication related to your spinal cord injury that causes loss of sympathetic tone. Naiintindihan? Okay. Ayan, so no PP daw, si no PP. Ayan, si signs and symptoms natin. Tingnan natin si signs and symptoms. Ayan, signs and symptoms tayo. Okay, signs and symptoms. Okay, yun ha. Pagdating sa volume, that's your preload. That's talking about hypovolemic and your obstructive shock. Pagdating naman sa contractility, you're talking about your heart. That is your cardiogenic shock. Pagdating sa distributive shock, you are talking about your blood vessels, guys. And that is your septic shock, anaphylactic, and neurogenic shock. Okay, let's talk about your signs and symptoms. Okay, that's your baseline of your signs and symptoms. Okay, famous natin is your hypotachytachy. Ayan, very good. I'm gonna write here blue as your signs and symptoms. Your hypovolemic shock is famous for your what? Hypotachytachy. Ayan. Yan, si hypo, tachycardia, and as well as your tachypnea. Alright? Famous po yan siya dyan, di ba? Your cardiogenic shock is what? Cardiogenic is what? Hypotachytachy din? Yes, it's hypo, tachy, and tachy. Ayan. What about your septic shock? The same thing. Hypo, tachy, and tachy. There you go. That's the basic, signs and symptoms. What about your anaphylactic shock? The same way. Hypo, tachy, tachy. All right. Neurogenic shock is different. You have hypotension. If you look at it, all of them are with hypotension. Kasi nga, we're talking about your blood pressure here, circulatory shock. All of them are circulatory shock. I did not mention here spinal shock because spinal shock is a false shock. How come it's a false shock? Because it doesn't talk about your circulatory system. All right. No, there's no low blood pressure in spinal shock. All right. It can be, it can be low blood pressure or high blood pressure. Well, but it's a false shock because it's not circulatory in nature, unlike your neurogenic shock. Again, this is your neurogenic shock, which is your hypo, tachy, and brady. All right. Brady, in a sense, that's your bradycardia. Remember, there is loss of sympathetic tone, right? There is loss of sympathetic tone. If it's loss of sympathetic tone, it also refers to your heart. All right? Again, sympathetic response to your heart is causing increase in your heart rate by releasing your norepinephrine that binds into your, this time it's your beta-1 receptors. If you have loss of that sympathetic tone, there is no binding of your norepinephrine to your beta-1 receptors, thereby causing decrease in your heart rate. Simple. Again, normally your sympathetic nervous system innervates your heart. Again, this is your nerve. Norepinephrine is released. It binds to your beta 1 receptors. Beta 1, you only have one heart. That's that's how I understand it. Beta 1, you only have one heart. Beta 2, you have two lungs. So beta 2 is found in your lungs. We have two lungs kasi. Beta 1 is you only have one heart. So it's found in your heart. Though there are some beta 2 receptors also found in your muscles then. But anyway, so this is your innervation. Normally, it innervates again your heart by increasing your heart rate. Okay, your norepinephrine binds to your beta 1 receptors, increasing your heart rate. But since you already have your loss of sympathetic tone, apart from your sympathetic tone in your blood vessels, it causes your decrease in your heart rate. That's why you have bradycardia. That's the only shock that causes bradycardia, and all the rest of them are like hypotachytachy. What about your there you go. What about your we have to categorize as well your shock as your warm shock and as well as your cold shock. Okay, warm shock or cold shock. What about these two here? Hypovolemic, cardiogenic, obstructive shock. These are what we call as what? Warm shock or cold shock? Come on, guys. Warm shock or cold shock? Itong nandito sa heart natin. Sa category ng heart, sa systolic blood pressure, what happens? Is this warm shock or cold shock? Okay, cold shock. We call them as your cold shock. Okay? Because cold shock because your extremities are becoming cold. Okay? Your extremities are becoming cold. All right. So kasi when you touch your patient, they are like, malamig po sila. Cold, clammy skin. Ayan, si cold, clammy skin. Ayan. This category here, distributive shock, all of them, this is talking about blood vessels, right? This is talking about blood vessels. If your blood vessels are dilating, what kind of assessment are you going to assess to that patient in terms of skin assessment? Tawag po natin dyan is warm shock. Okay? Warm shock po ang tawag dyan. Okay? Warm shock. So warm skin. That's why they are called warm shock. All of them po. Ito yung sinasabi ko. Hindi po lahat ng shock are cold and clammy. Meron po tayong tinatawag na warm shock, which belongs to your distributive shock. Because if you know that distributive shock is the blood concerning your blood vessel, and you know these blood vessels dilates, and you will know what happens to the skin. That's why you will have your warm skin. That's why they're called as your warm shock. Okay? So warm shock po yan siya kasi nagda-dilate po ang blood vessel. So the blood are also like leaking from your blood vessel, causing you to have like warm sensation or warm skin. Okay? Dito naman, it's understandable if you have like decreased volume and decreased contractility, for example, in your cardiogenic and hypovolemic and your obstructive shock, natural, magiging cold talaga ang extremity mo niyan. Alright? Because there's no pumping and there's no volume. Alright? And this does not involve your blood vessel. There's no dilating here. It's just that your heart is not able to provide a stroke volume and your heart is not able to provide a good volume. Okay? So ganun ang nangyayari sa atin. Why you have your cold shock. Alright? Hindi nakakaabot dun sa extremities natin. Okay? And in here, the problem is your what? The problem is your blood vessel. That's why it becomes leaky. That's why it's called warm shock. Okay? Naintindihan? So what else are the problems here? Let's go specifically to what? Cold, clammy. Ayan sila. Cold shock, cold, clammy. Ayan. So, si cold shock and your warm shock. Ayan. So tingnan natin ang ibang signs and symptoms natin. Other signs and symptoms involving shock. These are general signs and symptoms. The patient becomes confused, agitated. These are all CNS problem. Remember, if you have decreased perfusion to your brain, what's going to happen? Actually, it doesn't only apply to your brain. It also applies to any tissues in your body. Okay? Pag nauubusan, if you have hypoxia, pag nauubusan ng blood volume yan, it causes hypoxia, it causes hypoxemia. All right? It can even cause ischemia. All right? Pag sinabi mong hypoxia, you're not talking about oxygen. Pag sinabi mong ischemia, you're not only talking about oxygen, you're also talking about your sugar. all in all, your sugar and your oxygen, like I said earlier, that's the that's the materials for making your ATP. These are the chemicals that you need to form ATP. Natural, mauubusan ng energy ang pasyente. Any tissues in your body, magwawala po yan sila. They're gonna get wild because where's my oxygen? Where's my blah blah? Where's my where's my glucose? Where's my nutrients? Magwawala sila, just like your brain. That's why the patient becomes confused, becomes agitated, becomes anxious. All right? Anxiety, ayan siya. In other words, level of consciousness is is a problem here. Confused, agitated, and anxious as well. Give me other signs and symptoms, guys. Give me other signs and symptoms. Okay? But these are the major signs and symptoms natin, di ba? These are the major signs and symptoms. Okay. So let's take a look at a different since we categorize it according to my illustration. Bibigyan ko kayo ng another illustration here. All right? I'm going to give you another example, another principle for you to understand what is shock. And then you will identify what kind of shock belongs to this illustration. Normally we have we have this. I-draw ko muna ha. And then ayan. And this is your brain. Ayan. This is your brain suspending. This is your tank, by the way. This is your tank. Okay. This is your tank. All right. And this is your fluids. That is basically your blood volume. All right. That's your water, for example, or fluid. And as well as your pump. You will like this, guys. Okay, that's your pump. These are the three main or important players of your circulatory system. Okay, so we have your tank, which is represented by your blood vessel. Or the blood vessel is represented by your tank. Okay, and your number two, the fluid, is represented by the blood volume itself. Okay, that contains your blood, at the same time your water, the fluids in your blood vessel. And your pump is representing your heart. Okay, it's representing your heart. This is a normal person. You have a good functioning heart, a good functioning pump to pump out blood, and that's your fluid, into your brain to perfuse your brain. Okay, and you have to have a normal amounts of fluid, blood volume, in order to perfuse your brain. Okay, and the size of your tank right here, that is representing your blood vessel. If you have a good amount of, the normal size of your blood vessel, talking about normal size, you're talking about constriction and as well as your dilation. Okay, so it means to say, if it dilates, what's going to happen? Let's figure out. Okay, again, this is a normal person. You have to have a good pump, normal size of your blood vessel, and a normal blood volume in order for you to perfuse your brain in a normal individual. Okay, what happens in your shock? Okay, for example, gaya ko dito. All right. This is your tank, which is too large. Ayan. This is your pump. And this is your brain right here. And this is your fluids. I would say the tank is the problem because it's too large. So this is your blood vessel, right? This is your blood vessel. Okay, this is your blood vessel. So the tank is too large. In other words, it's dilating. All right, it's vasodilating. Intindihan? All right. There's no problem in your what? In your number two, which is your blood volume. Your blood volume, there's no problem. It's normal. Okay. The same thing as with your pump. Your heart. All right. Your heart or the pump itself is normal. In other words, your heart is normal. Okay? So the problem here is your tank. So what do you think? What type of shock is this? The problem here is that your tank is too large. You think your fluids, even if your heart is pumping really good against gravity, you think this fluid volume will reach your brain, will perfuse your brain? No, because again, the tank is too large. In other words, it's vasodilating. So this is a kind of your what? What kind of shock is this? This is your what? This is something to do with your blood vessels, guys. This is something to do with your blood vessels. Okay, this is what? This is your distributive shock. Something to do with your blood vessel. Okay, something to do with blood vessel. In other words, this is your sepsis or septic shock, neurogenic shock, and at the same time, your anaphylactic shock. Ayan. So tatlo po ang ating distributive shock. Why is called distributive shock? Because again, your fluids are distributed. Instead of in your blood vessel, it's distributed because the blood vessel is becoming leaky. It goes into your interstitium. Once it goes into your interstitium, it surrounds your, your tissues. Your oxygen cannot diffuse well in your tissues. That's why it can cause hypoxia. All right. So what about the second illustration here? Again, the tank size is normal. All right. All right. So the tank is, this time the tank is normal. Second, the blood volume is, or the fluids is also normal. The problem here is the pump. In other words, the heart. Heart is abnormal. There you go. The blood volume is supposed to be normal. However, there is no pump. There is no heart. There's no functioning heart that pumps out your what? Your fluids, your blood into your brain against gravity, right? So there's a problem here. Ayan, sira ang kanyang heart. This is a problem in your contractility. This is not a problem in your preload. This is not a problem in your blood volume. Okay? So this is, what kind of shock is this? Kind of shock is your cardiogenic shock. That's your cardiogenic shock po. Okay? Okay, let's move on to the next one. Okay. Ito naman, ayan siya. The pump is normal. Lagyan natin dito si pump is, or the heart is normal. Okay. The problem here is the blood volume. Blood volume is the problem. You have decreasing blood volume, maybe brought about by your what? By, like I said, your DDDs, your diarrhea, dehydration, those kinds of things, nausea, vomiting, decreased blood volume, or bleeding. And your tank is in normal size. Normal size. Dito po ang abnormal is the blood volume. All right? The blood volume is decreased. Ayan, si decreased blood volume. All right. So this is a form of your what? What kind of shock is this? This is your hypovolemic shock. Okay? Like I said, the fluid is right here. And ayan, si brain. Do you think this fluid can go there? No. Even if you have a normal functioning pump, you cannot perfuse your brain because the problem is you have decreasing volume. You have decreasing blood volume. You have decreasing, fluid volume in general. Okay, we call it as your hypovolemic shock. All right? We call it as your hypovolemic shock. Baka tayong mag-yellow. All right. Naintindihan? Or the other one is your obstructive shock. Again, because obstructive shock talks about your preload as well. It also talks about your blood volume that goes in your ventricles, both of your right and your left, decreasing your cardiac output, decreasing your blood pressure. Okay? Ito po ang ating illustration about shock. Again, this is a normal individual. This is another illustration, guys. This is a normal individual with a good pumping heart, with a good normal fluid volume or blood volume, with a good size of the tank, with a normal blood vessel size, not constricting, not dilating. It's just normal. Okay? It will normally perfuse your brain. And apart from that, it also perfuse your other organ system in your body. Now, if you have problem in your tank, what's going to happen? It dilates. The problem is that there's no problem in your pump, there's no problem in your heart, there's no problem in your blood volume. The problem here is that it's just too large because it's dilating. The blood vessels, the blood vessels here, that's what we call as your distributive shock. On the other hand, pag sinabi mong cardiogenic shock, there's no problem in your tank. There's no vasodilating or such things. Blood volume is normal. The problem is the pump. Okay? If the problem is the pump, you're talking about simply your cardiogenic shock. All right? It cannot reach your, your brain and other tissues in your body. Okay? Because the pump itself is abnormal. Okay? And that's your cardiogenic shock. Okay, lastly, normal tank, normal pump. The problem is that you have decreasing blood volume. All right? You think it can go to your brain? No, that's your hypovolemic shock and as well as your obstructive shock. Because obstructive shock also talks about your preload. It also talks about your fluid volume. Okay? And that is your shock, guys. Okay? So, tingnan natin ha. So, any questions about this one? Siguro I will focus on your sepsis, septic shock. I'll focus on your septic shock and then i-ano natin kasi ito yung pinaka-importante dito na concept eh. I mean na topic. Okay, your septic shock. 1 out of 3 patients in the hospital die because of shock. That's according to CDC. That's a big number. Okay? The microorganisms nowadays are evolving. Okay, again ha, 1 out of 3 patients in the hospital die because of sepsis. That's a big number. It's about 35 to 40% of the mortality. It's because of sepsis. In other words, you will expect that in your NCLEX, especially talking about critical care. All right, that's why I'm discussing this one, your critical care, specifically your septic shock. Okay, so I guess I can still talk about septic shock. Okay pa ba tayo? Do you have any questions, guys? Okay. Sir, what about narrow pulse pressure? Narrow pulse pressure and as well as widened pulse pressure. Where can you see the narrow pulse pressure, guys? Where can you see the narrow pulse pressure? You can see it in your the narrow pulse pressure. You can see it in your in your cardiogenic shock and your hypovolemic shock. Okay, your cardiogenic shock and your hypovolemic shock. Narrow pulse pressure. Bakit hindi mag-blue? Ayan, this is your narrow pulse pressure. Dito naman, it's widened pulse pressure. All right.
Jay, sorry to interrupt. I think ang pen is very light.
Oh, okay. I'm gonna ganyan. How about that?
Yes, better.
Nilakihan ko na lang para siya. For those who are like using cell phones, I guess hindi nakikita na. Anyway, this is your narrow pulse pressure. On the other hand, this is your widened pulse pressure. Okay. So, bakit siya narrow pulse pressure? How do you define pulse pressure, by the way? Your pulse pressure is, let's talk about management pala, sorry. Your narrow pulse pressure is basically what? I mean, pulse pressure is di ba? When you, this is your systolic blood pressure minus diastolic blood pressure. Just minus, di ba? Systolic blood pressure minus your diastolic blood pressure, that's your pulse pressure. Okay, one pulse pressure is, when you subtract the same thing, pulse pressure. All right, tingnan natin dito. Talking about your systolic and your diastolic blood pressure. All right, if you have problems in your heart, for example, all right, if you have problems in your heart, this is the normal blood pressure, by the way. If you have problems in your heart, what's gonna happen? The problem is the hypovolemic, cardiogenic, problems in your preload, in your volume, at the same time, your contractility. Okay, let's just say ito, bumababa. Ayan, bumababa siya. Ang nangyayari is, for example, nagiging 90. Ayan, that's why, because the problem itself is in your heart. The problem itself is in your systolic blood pressure. That's why nagnanarrow ang pulse pressure. 90/80. There's no problem in your diastolic blood pressure. The problem here is your systolic blood pressure. It still compensates. All right? It still compensates. However, later on, if you are decompensating already, loss of physiologic balance ka na. In medicine, we call it as your decompensation. We call it as your loss of physiologic balance. You still compensate. Kung tumataas dito ang, for example, kung bumababa siya, let's just say 100. Okay, problems in the contractility, problems in the volume. I need to increase my diastolic blood pressure. I need to increase my your systemic vascular resistance. It becomes 90. Okay, that's why the narrow pulse pressure decreases. The pulse pressure decreases or narrows. Okay, because it's able to compensate. However, if you already have your decompensation, what's gonna happen? This will eventually go down as well. Okay, this will eventually go down 100/60, 90/60 until such time na maging 80/40 na lang siya. Okay, that's profound shock already. That's an obvious shock. It's not occult shock anymore. Pag sinabi mo kasi occult shock, even if the patient has, other symptoms, but the blood pressure is still, okay, that's a form of your occult shock. They still have reserve in their body, to produce a good blood pressure. But anyway, I'm not gonna talk about occult shock and your profound shock as well. On the other hand, widened pulse pressure. Ito, the problem here, the normal blood pressure is what? 120/80. This is talking about your diastolic blood pressure. This is talking about systemic vascular resistance. This is talking about distributive shock. 120/80. The problem here is your diastolic blood pressure. It becomes, for example, 40. All right, nagiging 40 na siya. There's no problem in your systolic. There's no problem in your preload. There's no problem in your contractility. The problem is your what? Is your systemic vascular resistance. The problem is your blood vessel. That's why you have widened pulse pressure. But eventually, magko-compensate din kasi yan eh. This one will compensate. It will become, for example, 140/40. Okay? Your heart will compensate because your blood vessels are not working well. Your heart will compensate by increasing the fluid volume, increasing the preload, at the same time increasing its contractility. Kaya tumataas ang kanyang systolic blood pressure. All right? But again, in decompensating states, in loss of physiologic balance, later on, bumababa din yan siya. Magiging 120, magiging 100/40, until such time na magiging 90/30. Ayan, super baba na siya. It's the same thing. All right. So initially they'll have like narrow pulse pressure for your hypovolemic shock, obstructive shock, and your cardiogenic shock. And on the other hand, when you say distributive shock, they can have widened pulse pressure initially, but later on they will end up having low blood pressure to both systolic and diastolic. Okay, naintindihan? Pag sinabing early stage of shock, anong i-answer natin? For example, early hypovolemic shock, narrow pulse pressure. Pag late decompensating shock na siya, so basically, there's no such thing as narrow pulse pressure, widened pulse pressure. Definitely, it's profound, hypotension na talaga yan siya. Okay? So sa initial stage lang po ng shock nakikita natin to. Pag sinabi mong distributive shock, initially it's widened pulse pressure. Pag sinabing profound shock na siya, there's no such thing as widened pulse pressure, vice versa. Okay? Ayan, see, in terms of pulse pressure, let's talk about management dito. Let's talk about management dito. Okay. So I'll make it white na lang siya. Okay, management. I'm gonna make it white. So management natin, hypovolemic shock. What's our management here? What's our management? It's natural. It has to be what? It has to be fluids. Okay, it has to be fluids. And of course, if you have bleeding, you have to have blood transfusion. Okay, you have to have blood transfusion. What about in your obstructive shock? The same way, fluids and of course fluids. Ayan. Can you give pressors? Can you give pressors? Yes, you can give pressors. Okay, you can give pressors, your inotropics. All right, your inotropics. What about in your cardiogenic shock? Can you give fluids here? Are you going to give fluids here? Are you going to give fluids? The priority is what? Fluids or your pressors? Come on. Fluids or pressors? Come on, come on. What's your fluids? No, you cannot give fluids here because this is CHF. Optimum fluids lang po tayo. All right? Remember, your CHF will only get 1,500 liters, 1,500 ml per day lang po yan sila. Alright, this is CHF eh. This is a form of CHF. So priority here is pressors. Priority is pressors. Minimal fluids lang po tayo. Because the problem here is the contractility. Naintindihan? If you don't know this illustration, if you don't know the principle that contractility talks about your cardiogenic shock, you will just only give fluids to your patient. No, you will simply causing death to your patient. You're simply causing mortality. Pressors po ang priority because the problem here is the contractility. The problem here is the heart. All right, this is CHF. Okay, so pressors. Ayan. So what about here? You have your fluids as well, and at the same time your pressors. Ayan, priority talaga ang fluids natin. What amount of fluids are you giving, sir? About 2 to 3 liters. 2 to 3 liters of bolus. Bolus po yan siya, or 30 ml per kilogram. Yan, 30 ml per kilogram. That's about 2 to 3 liters of bolus you can give to your patient. Okay? So priority natin yan because you need volume here. You need volume. Kailangan lagyan ng volume dito so that you will have a good vascular resistance. The more fluid volume you have, the more increase in your blood pressure, because the problem here is your circulatory. The problem here is your blood pressure. The same way as your anaphylactic shock, the same way as your neurogenic shock. Okay? Of course, you cannot correct your spinal cord injury then. All right? So, give fluids. Give fluids so that you will increase your blood pressure, so that you will not cause hypoxia, so that you will not cause, ischemia as well. All right. So, what about here? Pressors, kasi nga, the problem is contractility. Fluids in your preload and volume problem, yung hypovolemic shock, obstructive shock, because the problem here is the preload. The problem here is the volume. So you give fluids. If the patient does not respond to your fluids, give pressors. Okay? Give pressors to increase but the priority here is your fluids instead of the pressors. On your cardiogenic shock, the priority is your pressors, not the fluids. You don't want to give fluids on a CHF patients. Diba? Sabi ko CHF, cardiogenic shock is the severe form of your CHF. All right? So ganun lang po yun siya. Okay, so let's talk about your septic shock. Naintindihan to ha, naintindihan. Let's talk about your septic shock. Okay, if you are on a review program, whatever review program you have, maybe from IPASS or some other review centers, you will have to definitely encounter this. There's no way that you will not encounter this because, like I said, this kind of lecture, because like I said, 1 out of 3 according to CDC dies because of what? Sepsis. All right, so it's just right to discuss about the sepsis continuum. So this is your sepsis continuum, guys. I'm gonna discuss to you about sepsis continuum. Anong nangyari? At ayaw na mag-white. Ayan. So sepsis continuum tayo. Oops, ayaw. Kaya natin si ano. Ayan. Sepsis continuum. Ayan. I'm gonna review about what happens to your to your sepsis. This is your blood vessel. Are you still with me, guys? This is your blood, of course, with the antigenic material here. Ayan, si antigen. Ayan. And this is your white blood cells. Of course, your white blood cells will recruit other white blood cells, di ba? From your T helper cells, it will recruit your B cells to produce antibodies. It will also recruit other blood cells, for example, your neutrophils, your eosinophils, and so on and so forth. Okay, again, WBCs recruit other blood cells or white blood cells to produce chemicals, to produce inflammatory mediators that causes, inflammation. All right, that causes inflammatories. That's why they are called like inflammatory mediators, because they mediate inflammation. All right. So one of them is your nitric oxide. Yan, si nitric oxide. Your nitric oxide causes what? Increased permeability, like I said earlier. So increased permeability, there you go. Fluids are going outside. Okay, fluids are going outside, surrounding your tissues the same way as I discussed earlier. Surrounding your tissues, causing what? Decrease oxygen to your what? Oxygen to your tissues. Okay, decrease oxygen to your tissues. Okay, one of the problems here in your septic shock is what? One of the problems here is production of your lactic acid. I'm gonna emphasize this one. So I would say the second mechanism that will happen is increased permeability. Okay. In other words, leakiness, increased leakiness of your blood vessels, and then thereby causing hypoxia. Ayan, hypoxia to your cells or to your tissues. Okay. And I'm gonna emphasize on this one, increase in your lactic acid. Okay. If you have hypoxia, chances are you will have your increase in your lactic acid. Okay. Our parameter here is 2. If it's more than 2 already, millimole, that's about 18 milligram per deciliter. Okay, millimole per liter. If it's more than 2 already, that's increase in your lactic acid. It might be because of your sepsis. Okay, it might be because of your infection. Again, our parameter here is 2. If it's more than 2 already, well, that could be a sign of your. That's not only the sign though. I'm gonna discuss about that sepsis continuum later. So anyway, so this can be a sign of your impending sepsis, increase of lactic acid. Why? Because if you have hypoxia, aerobic metabolism, your body tends to shift into anaerobic metabolism. All right? So your muscles tend to, saan ba napuproduce sa muscles eh? Di ba? Saan napuproduce sa muscles? Your body tends to shift into another metabolism, which is your what? Anaerobic metabolism. Right? Your anaerobic metabolism produces your pyruvates by causing more profound glycolysis in your liver. What's gonna happen? They produce pyruvate. Once they produce pyruvate, chances are they will also produce your lactic acid. It's a long equation of your chemicals. I'm gonna shortcut this equation. Anyway, if you have hypoxia, that's well, oxygen is aerobic metabolism. It will shift into anaerobic metabolism. It will tell your liver, hey, I'm not getting enough nutrients here. I'm not getting enough oxygen. Please increase your sugar by breaking down your glycogen. That's your glycolysis. That's in your liver. The byproduct of this is your pyruvate. Shortcut natin, the byproduct of your glycolysis in the presence of your anaerobic metabolism, in the presence of your hypoxia is what? Is pyruvate. Pyruvate, the byproduct, of the total equation is your lactic acid. Okay, that's why in your sepsis, because of hypoxia, it will increase your lactic acid. Where can you find this? In your muscles. Hey, muscles kasi, you're composed of muscles in your body. It's a big amount of muscles in your body. So, siya yung nangangailangan ng oxygen. Siya yung nangangailangan ng sugar to form ATP. That's why lactic acid is produced in the presence of hypoxia in your muscles as well. Not only in your muscles, but as well as in your other tissues in your body. Okay, so this is your sepsis continuum. Sepsis continuum is, from the word itself, it's continuum. It's just simply talking about the severity of your sepsis from one stage to another. So this is your what? Sige nga, kung may idea kayo nito. All right, this is your SIRS. All right. SIRS is also known as your what? Systemic inflammatory response syndrome. Okay, systemic inflammatory response syndrome. What are the criteria of your SIRS? Ano to? Systemic inflammatory response syndrome. Ayan siya. Systemic inflammatory response syndrome. What are the criteria of your SIRS? Okay, criteria of your SIRS, guys. What are the criteria? Criteria natin. Okay, number 1 is your temperature. Temperature of 36. All right, temperature of 36 degrees Celsius. Convert it to your Fahrenheit. It's about 96.8 Fahrenheit. Or 38 degrees Celsius. Or 100.4 degree Fahrenheit. Sa America po, Fahrenheit. The good thing about NCLEX is that they will give you the Celsius at the same time. They will also give you the Fahrenheit, which is a good thing. But here in the US, in our practice, it has to be Fahrenheit. You don't know much about Celsius then. But I'm giving it to you guys. 36 degree Fahrenheit or 96.8, 38 degrees Celsius or 100.4. So that's one criterion. All right. What about your RR, respiratory rate? It has to be more than 20 cycles per minute. Okay, or 30 breaths per minute. More than, more than. Okay, what about your heart rate? You don't need to be 100, at least 90 beats per minute is fine for your heart rate, for you to know, oh, okay, the patient is tachycardic. In other words, this is tachy, di ba? And this is also tachy. Yeah, this is in response to your infection. All right, this is in response to your infection. What else? Your WBC. Your WBC is less than 4,000 or more than 12,000. Ayan. So this is leukopenia. This is leukopenia, and this is your cytosis. This is leukopenia and your leukocytosis, WBC. Leukopenia and leukocytosis. If your WBC is elevated or decreased, well, you can say it's a criterion for what? For determining there is something wrong with my patient. Oh, considerably my SEERS ang pasyente. At least, how many? 2 out of 4. Okay? 2 out of 4 plus other symptoms. For example, like confusion, agitation, mga ganun. Level of consciousness. But anyway, these are the primary criteria for your SEERS. These are SEERS criteria. Alright? Pag ang pasyente, oops, there's an evolving infection, guys. Ayan. So this is what we call as your sepsis. All right? This is already your sepsis. Okay. Your sepsis is SEERS plus what? Plus the source of infection. You now know, for example, may pneumonia. May UTI ang pasyente. Klebsiella ang kanyang pneumonia. Klebsiella pneumoniae. Streptococcal. ESBL, Pseudomonas, MRSA. Madaming causes ng pneumonia. Alright? Most of the time, streptococcal, right? But in the hospital, if it's hospital-acquired pneumonia, it's usually Klebsiella coming from aspiration, or pwede ring MRSA, pwede ring Pseudomonas. Pseudomonas is not as common as in the Philippines. Here in the US, is mostly MRSA. Your methicillin-resistant Staphylococcus aureus. Sometimes it's sensitive. We call it as your MSSA, methicillin-sensitive Staphylococcus aureus. But it's the same, Staphylococcus aureus. All right? But the bad thing about methicillin is that, it's resistant to antibiotics. All right? And UTI, most commonly E. coli. Ayan. In other words, you already identified the source of infection plus the SEERS. Ayan, plus the SEERS tayo. Okay, I'm going to emphasize this using yellow. Ayan. So again, what is SEERS? Systemic inflammatory response syndrome with the criteria, 2 out of 4 criteria plus the SEERS. Plus the source of infection. That's what we know as your sepsis. All right. Okay, the next one would be what? If you did not treat this well, if it's already profound, for example, ayan. Okay. Are you still with me, guys? Ayan, meron pa pala sila dito. Marami pa rin nanonood sa atin. All right. So this is already your septic shock. Okay? Septic shock. This is the continuum, ha? Ayan, si continuum. Ayan, this is your septic shock. From the word itself, meron na siyang shock. So this is your SEERS. Ayan. Plus the sepsis. Plus, when you say shock, there's already decreasing blood pressure. Okay? Decreasing blood pressure na siya. All right? The blood pressure is, again, it could be widened pulse pressure. All right? Initially. All right? And later on, the systolic blood pressure becomes 90 or less. Okay? Ayan siya. Ibig sabihin, the patient is decompensating already. The patient is already, losing its physiologic balance. It compensated in a sense. Naging 120/40 siya because the problem here is, this is the distributive shock. The problem here is your diastolic blood pressure. The problem is your systemic vascular resistance. All right, it compensates, the heart compensates. However, later on, magiging Mababa na rin to siya. 90/40, for example. Alright? So decreasing blood pressure. Profound shock na po yan siya. That's septic shock. Sears plus sepsis, identified source, and low blood pressure. Even if you give bolus, ayan, problema yan. Kasi nga, magiging multi-organ system dysfunction na yan siya. But anyway, I want you to take a look at this illustration here. Okay, I'm gonna write here in between your severe sepsis. This is very crucial. All right, this is very crucial. It's make or break. Make or break in a sense that this can go to the floor and this can go to ICU. All right, so severe sepsis, that's where we think na is this patient will go to ICU or should stay on the floor. Okay, in your severe sepsis, the lactic acid is already increased. All right, more than 2, like I said, millimole. And your MAP is starting to get low. All right, starting to get low, which is what? What's the normal MAP, by the way? 65 to 110, di ba? Some books will say 70 to 110. MAP is, how do you measure MAP, by the way? Your 2 diastolic blood pressure plus systolic blood pressure divide 3 at your MAP. That's equal to your cardiac output. If you have, for example, my illustration, di ba? Your MAP is basically equal to cardiac output. Now, if your MAP is low as well, ibig sabihin, there's already a problem in your heart. It's not contracting well. It's not having a good preload. It's not having a good heart rate. Magiging problema yun. All right? So, MAP is less than 65. Okay. It's starting to get low na. All right? It's beginning to look like Christmas. Anyway, it's beginning to go down. Ayan, si severe sepsis. Before it becomes profound shock. In other words, dito mo na makikita ang widened pulse pressure kasi nga it's distributive shock. Okay, so lactic acid, these are the parameters that you need to know. Ito yung mga pinaka-importante. Alright? The patient can have starting or beginning elevated BUN creatinine. So also check for the secondary parameters as apart from your lactic acid and your MAP. Elevated BUN creatinine is a signal, is a sign that you may have an impending kidney problem already or an organ system dysfunction. Organ system dysfunction beginning. That's why it's very crucial. Organ system dysfunction. All right, organ failure. All right, if your liver is also your AST and your ALT is becoming elevated, that's a problem. Beginning, it's beginning to get elevated, especially your BUN and creatinine. All right. So, meron ka ng beginning organ system dysfunction. But I want you to look at primarily your lactic acid and as well as your MAP. The question is, are you still with me, guys? Andito pa ba kayo sa akin? Oh, QSOFA score. That's the index that we're using also, right? But this one is ano to siya? It's a combined, combined kind of illustration, guys. All right? Ano daw sabi? Yes, are you still with me, guys? Okay pa ba tayo? Yes po. Okay, we have a good discussion here, guys. Severe sepsis, why I am discussing this one? You know why? Because it's very crucial, like I said. This one can go to the floor and this one can go to ICU. We don't want patient to go to ICU because they will die because of many kinds of complications in ICU. As much as possible, if we can control them to keep them in the floor, we'll have to keep them in the floor. But if they needed to be in ICU, then wala tayong magagawa. They have to be in ICU. All right? Titimbangin natin kasi maraming complications sa ICU, pneumonia and so on. Another sepsis na naman yun. Prolonged stay in the hospital. All right. So, ito, organ system dysfunction, ayan, especially your BUN creatinine. Well, like I said, I want you to look at your lactic acid and your MAP. Okay, that's the severe sepsis. Okay, our goal here, since we talk about this, this severe sepsis, our goal here is to have early management. They call them as your early goal-directed therapy. Early goal. Should I just write early goal? NCLEX will not ask anong klaseng what's the definition of this early goal therapy. what's the, what's the mnemonic or something, what's the abbreviation. No, just simply call it as early goal. In other words, as soon as possible, you intervene, you take care of this patient with this goal. I mean, with this kind of approach. Okay, number one is fluids. Okay, our early goal is to give them fluids. Okay, and of course, as soon as possible. This is very much applicable, very consistent to the studies that they're talking about. Antibiotics are actually useless if you're going to give it during septic shock. Don't wait for it to become septic shock before you give antibiotics. That's why SEERS pa lang, sepsis pa lang, nagbibigay na tayo ng antibiotics while waiting for your culture. All right? Because culture comes like 2 days, 3 days. May preliminary after 1 day, but it's preliminary. No, it's cross-contamination lang pala. It usually comes in by 3 days. We can't wait for that. Give antibiotics. Because if you give antibiotics, during septic shock, it will become useless. We don't want that. So antibiotics tayo. And what kind of antibiotics we're giving? Empiric. Empiric antibiotics. All right? It means to say it covers gram-positive and gram-negative. Okay? Gram-positive and gram-negative. Gram-positive, for example, MRSA, Staph aureus are gram-positive. Okay, we don't know it's ESBL. ESBL is what? ESBL is gram-negative. Pseudomonas is also gram-negative. Okay? Klebsiella pneumonia is also negative. So, it's just right for us to give empiric antibiotics. All right? It covers both gram-positive and gram-negative. Okay? So, antibiotics kaagad yan. Another thing is that, okay, hydrocortisone. All right. That's a good question, hydrocortisone. Isisingit ko yan dito. I mean, that's a good, Miss Jaja. Okay, source of infection. Remove the source of infection. Ayan. How can you remove the source of infection? The possible source of infection. If you have, for example, you already have like 3 IV lines. You don't need it. Remove it. You only need 1 IV line. If you already have the central line, remove the other lines. Hindi mo na kailangan yun. That can be a source of infection. If you have, for example, if you think that this patient doesn't need that IV line, then remove the IV line. Club C, remember? Club C, central line, associated bloodstream infection, or could be peripherally inserted, peripherally related infection is related to peripheral IV, those kinds of things. That's why, for example, in your catheter-associated infection as well, in your COTI, in your catheter-associated UTI, as much as possible, we don't also, insert Foley catheter if the patient doesn't need it. But anyway, this is sepsis. The patient needs it. Well, if you think that Foley catheter has been there for like 2 weeks already, that's a source of infection. Reinsert. Of course, when you reinsert on a sterile manner, of course, di ba? So remove the source of infection and then insert another one in terms of Foley catheter. But in terms of IV, as much as possible, please, iisa or dalawa. If you have the central line, that's good enough. Huwag ka na mag-insert ng another IV. That can be a source of infection. Remove these indwellings, guys. Indwellings are one of the causes of your infections, right? Especially in the hospital setting. Okay, for example, your IVs and your Foleys as well. Remember, Foleys are the sources of your catheter-associated UTI. IVs are, it can cause infection. Central lines can cause central line bloodstream infection, associated bloodstream infections. Anyway, remove the source of infection. If your patient doesn't respond to 3 cc per kilogram or 2 to 3 liters, di ba? You can start right away sa severe sepsis before the septic shock, happens. Fluids talaga. If it doesn't respond to your fluids, you can give your pressors. Right? You can give your pressors. Pressors can be in a form of your what? Norepinephrine, or your Levophed, or your dopamine. All right? Levophed and your dopamine as well. Okay? I call them as your inoconstrictors. Sir, it's a new term. For me, I call it inoconstrictors. You know why? In your going back into your pharmacology, blood vessel, heart. Okay, blood vessel contains alpha receptors. All right, stimulating your alpha receptors, binding your norepinephrine causes vasoconstriction. All right, vasoconstriction. Okay. Talking about your heart, beta 1 receptors. Beta 1 receptors causes what? Binding of your norepinephrine to your beta 1 receptors causes vasoconstriction as well. I mean, not vasoconstriction, increase in your contractility. All right. And also, it will also bind to your what? Alpha receptors. All right. In other words, an INO effect, which causes increased contractility. At the same time, constricts your blood vessels. All right. So double effect. All right. Double effect tayo. All right, so activating your beta 1 receptors at the same time activating as well, innervating also your, that's the right term, innervating also your alpha 1 receptors. That's why it's called as inoconstrictors. It increases your heart rate. All right, it increases your heart rate and increases contractility. At the same time, it increases your blood pressure by vasoconstricting. That's why it's called, I call it as your inoconstrictors. All right. Does that make sense? All right. Dopamine is good. However, it really increases your heart rate. Norepinephrine is also good. All right. In terms of, ang problema kasi ng dopamine is like increases chances of increasing heart rate at the same time, tachyarrhythmias. You know, tachyarrhythmias. All right. The good thing about norepinephrine has little effect on your heart rate. So it doesn't really cause your tachyarrhythmias. So I'll go with your norepinephrine. All right. So norepinephrine and your dopamine, these are inoconstrictors. Okay? Pag sinabi mo kasing vasoconstrictor lang, you're just simply talking about your vasopressin. That's only specific to your alpha 1 receptors. Again, that's only specific to your alpha 1 receptors. Pag sinabi mo namang beta 2 in your muscles, ayan. Okay, this is your inodilators. Inodilate, iba naman to. So I'm not gonna discuss anymore. Pag sinabi mo inodilators, this is your milrinone and as well as your dobutamine. All right? This is your milrinone. Oh, these are critical care concepts, guys. Milrinone and as well as your dobutamine. All right? Because beta 2 receptors can also be found in your muscles, all right? In your smooth muscles, blood vessels, and in your muscles. Anyway, I mean in your blood vessels as well. Okay, beta 2. Ayan, si beta 2. Ayan, it can cause dilation. That's why it can be called as your inodilators, right? That's another term, inodilators. But we'll go to the specific one, inoconstrictors, specifically your norepinephrine and your dopamine, because your patient is not responding to what? Fluids. You go with your pressors. Somebody said steroids. Very good. You know why? Steroids is very effective in your sepsis. You know what's the reason? Because steroids, I talked about alpha 1 receptors. I talked about beta 1 receptors. Steroids open up these receptor sites. Okay? Ganda naman. Steroids open up your receptor sites. They open up your receptor sites. If they open up and then you're giving inotropics, they will bind to that specific receptors. So it will cause inoconstriction. It increases your heart contractility, it increases your heart rate, increases your blood pressure, because you're talking about your blood vessel, systemic vascular resistance. Remember, septic shock is talking about systemic vascular resistance. Increase in your systemic vascular resistance. This is your early goal therapy. You need to know this as soon as possible. As soon as possible, well, you have to intervene the patient. You have to do these fluids, antibiotics, remove the source of infection. And if the patient doesn't respond to your fluids, pressors. In other words, the patient should go to ICU. Okay? Should go to ICU. All right. Kaya pa ba? All right. Because we have a late goal therapy. Late goal na tayo. All right? In other words, the patient is already in ICU, monitoring. It's the monitoring in ICU. Ayan. Late goal monitoring in ICU. You monitor the heart rate. This is already monitoring na lang. You're already giving your pressors at this time. Monitoring your heart rate, monitoring your contractility. Ayan, si contractility. Monitoring your systemic vascular resistance. Okay? In other words, your let's just say your preload. Okay, let's just say your preload. Ayan. Okay. Ayan siya. So monitoring your heart rate is simple. Monitoring your heart rate is just simple. Just monitor, the tawag niyan, your monitor, your heart monitor. Madali lang po siya, di ba? Monitor tachyarrhythmias, for example. If your patient is having Brady, ayan, tachyarrhythmias, ACLS natin, you pace your patient, di ba? If you have tachyarrhythmias, you have to shock your patient. Easy peasy. Pace or shock. Brady, pace, tachy, shock. Okay. Contractility. How about measuring your contractility? Okay. You measure contractility by measuring your what? Sabay na lang natin itong dalawa. Measure your what? Measure your, this measures your CVP. Ayan, sa CVP. Ayan, measures your CVP. Okay. It can also, di ba? Ang pasyente na nasa ICU, naka-CVP yan sila. You can also measure your what? You can also measure your your CVO2. Ano yung CVO2, sir? Ano yung, this is very important. If you're a critical care nurse, you have to know this. Your CVO2 can be taken from your venous blood gas. Okay. Your CVO2 normally should have more than 70%. In other words, this is your heart. Ayan, si vena cava. Venous blood contains what? Your venous blood contains 70% of your O2 sats. Saturated po yan sila ng 70%. Okay? Hindi po lahat ng oxygen na di-deliver sa tissues natin. Normally, it should be 70%. Just like in your septic shock. Okay? In your septic shock, if it's more than 70%, it means to say that's just septic shock. Okay? There's no other problem. If it's less than 70%, that could be cardiogenic shock. Naintindihan? Alright? So it's either, if it's more than 70% ng SCVO2 natin or CVO2 natin, the central venous oxygen saturation or percentage. Okay, if it's more than 70%, that's just septic shock. So go again, you just have to continue giving management for your septic shock. If it's less than 70% po, this is critical care, guys. I'm talking about this, I should have talked it simple, no? But well, I'm already here. If it's less than 70%, that could be cardiogenic shock. All right? Because in your tingnan niyo to ha. In your cardiogenic shock, the problem is the pumping, right? The problem is the pumping. It will take time for the blood to go to the tissues. All right? Ito yung tissues natin. Andito si tissues, so ayan. Ayan. It will take time because of contractility. We're talking about cardiogenic shock this time. Because of contractility, the blood is not going to the tissues on a right time. It will take longer for them to go to the tissues that needs oxygen. These tissues will get hungry of oxygen. Remember, this is what? My venous blood ka dito. They will consume the remaining oxygen from your veins. Ayan. That's why if it goes back to your venous circulation, to your superior vena cava and your inferior vena cava, what happens? It's already consumed. It has to have normally more than 70%. But this time, because your tissues are hungry of what? Oxygen. Because your blood in your cardiogenic shock, it doesn't reach the tissues well. What's going to happen then? So they will consume the remaining oxygen in your venous blood. That's why your vena cava and your superior vena cava will have lesser amounts of oxygen. If you get it, in cardiogenic shock, less 70%. In septic shock, there's no problem. There's no problem in septic shock. Considerably, it's still 70%. So this is, my point here is that this will let you know what kind of shock is this, because we have a different management in your cardiogenic shock and in your septic shock as well. You don't give much fluids in your cardiogenic shock and you give much fluids in your septic shock. Okay, so which one is, titimbangin natin yan by, by ruling out using your CVO2. All right. So what else? Ano pa bang natin dito? CVP, of course, if your patient is getting fluids, dapat nagiging normal yan siya, di ba? 0 to 12. Some other books will tell you 0 to 2 to 8. Pwede ring 2 to 8, pwede ring 2 to 12. Okay, just to give you an idea in NCLEX, the range is actually wide. For example, ang range ng ano natin ng potassium is like 3.5 to 5.5. Okay, you know why? Because they wanted to accommodate all other references. Well, in fact, for example, in a hospital, it can only be like 5.1, 3.5 to 5.1. 5.2 is already hyperkalemic. All right. So this is just a strategy, talking about NCLEX. Okay. So NCLEX accommodates, a wider range of, your lab values. Okay, for example, maybe the CVP in your NCLEX should be up to 12. Most of the time, it's like 0 to 8, 0 to 10. Some books will say 0 to 12. All right, we'll accommodate that, 0 to 12. So the NCLEX will tell you 0 to 12 in your CVP. It has to be 0 to 12. In other words, if it's more than 12, your patient is getting a lot of volume. All right, the patient is getting a lot of volume, so you don't want that. Okay, and another thing is that you can do your CVP, of course, you can see if your fluid is enough or kulang pa ba or something like that. All right. So again, this is monitoring in ICU. You can also do your IVC ultrasound. Paano yun, sir? Ultrasound. It's a Doppler, di ba? Ito ginagawa ng pwedeng ultrasound technician, pwedeng gagawin ng nurse in the ICU. You do ultrasound in your vena cavas, in your inferior vena cava. That's the easiest. Okay. If this one, when your heart contracts, if it collapses, kung nagko-collapse ang inferior vena cava, it means to say you still need fluids. You still want to give fluids to your patient. If that doesn't collapse, if it don't collapse, well, I think your fluid is already enough for this patient. Again, this is monitoring in ICU. Okay, so these are just one thing. These are just the things that you need to do when you monitor your patient having sepsis, severe sepsis in ICU. Okay, so basically in your late goal, masasabi na siguro natin na patient is already having septic shock, leading into what? The last stage is your what? Is your MODS. What do you mean by MODS? MODS is multiple organ dysfunction syndrome. Okay, multiple organ or multi-organ dysfunction syndrome. In other words, you already have your respiratory failure. Okay, the most common complication of your septic shock is basically your ARDS. ARDS is pulmonary edema on a non-cardiogenic, non-cardio na type. Okay, not because of a failure of your heart, not because of heart failure, but this is because of your septic shock. Okay, because of your septic shock. Remember this pathophysiology here. This pathophysiology is not only talking about one blood vessel. This talks about the blood vessel, for example, in your lungs. Okay, if it's already hypoperfused with oxygen, if it's already having problems in its blood vessel, you think it is perfused with oxygen? You think it can, it can eliminate as well as, your carbon dioxide? It cannot. All right. In other words, there's problem in your gas exchange. Okay, because of that. This is your alveoli. This is your blood vessel right here. It will give out carbon dioxide so that it will be eliminated, and it has to deliver. The oxygen will jump to your blood vessel, and then delivered to your system. It's not gonna happen, and that's because of your profound inflammation. Your blood vessel is already congested, vasodilating, and your interstitium is already congested. Your oxygen cannot diffuse well. Your carbon dioxide cannot diffuse well for your alveoli, for your lungs to eliminate it in the process of your, your expiration. It cannot. That's why it can lead into ARDS. Okay. The classic sign of ARDS is what? your hypoxemia, diba? All right, your hypoxemia, definitely. Even if you give oxygen, wala pa rin nangyayari sa pasyente. Even maximize na oxygen, wala pa rin nangyayari sa pasyente. All right? So this is basically tawag nito, it's a severe problem. Okay? So respiratory failure, you can also have elevated BUN and creatinine, leading into what? Acute kidney injury. That can also lead into chronic kidney injury. All right. Again natin, acute kidney injury, chronic kidney injury. Okay. And as well as what? In elevated AST and elevated ALT. It means to say you're already having liver failure. From the word itself, it's already multi-organ dysfunction syndrome. Think about your respiratory failure. The patient will die of this. Think about your kidney failure. The patient will also die with this because this has a lot of complication. Okay, I'm thinking about a word here. Hypoxemia. May isang word dito. Iatrogenic hallmark sign. What is it? There should be a first word for hypoxemia here. Can you give me that word? I forgot the word already. Something to do with even if you it's in my tongue, it's in the tip of my tongue. This is my last word. I have to give it to you guys. Hypoxemia. It's even if you give oxygen, even if you give the management, everything is maxed out. The patient is still having hypoxemia. That's the classic sign of ARDS. Okay. So well, this is your tingnan natin, i-review natin. Okay, systemic inflammatory response syndrome, that's your SIRS, 2 out of 4 criteria. Sepsis, you have SIRS plus identified source of infection. Again, this can go to floor or in ICU, especially if you're having severe sepsis already. In your severe sepsis, you have increased lactic acid already and decreasing MAP or mean arterial pressure. Well, if this is gonna happen, take note because this patient can go to ICU. Give fluids. Fluids and pressors, even fluids as soon as possible within 1 hour or 2 hours. This lactic acid will become normalized. Your MAP will become normalized, even with fluids. But if fluids is not, the patient is not responding to fluids, you give your pressors. Okay, you give your pressors. And apart from that, you have your antibiotics, your empiric antibiotic, which covers gram-positive and your gram-negative microorganisms. All right, and remove sources of infection. Now, if your patient is already in ICU, you have to have your monitoring. Like I said, your heart rate, contractility, and your preload as well. And apart from that, of course, your septic shock. Your patient is already having, of course, all of them are included, your SIRS, your sepsis, identified infection, and low blood pressure. Hypotensive na ang pasyente. If you cannot treat this patient, you can have MODS, all right? Your multi-organ system dysfunction. Okay? So this is your what? This is your sepsis continuum. We started with your low blood pressure. We ended up in your septic shock. And that is our lesson for today. All right? So any questions? So kulang pa ba or should I add more or what? Do you want me to do another lecture or what? Anyway, thank you for coming today. Ma'am Shell, are you there?
Yes, I'm here, Jay. Thank you very much, Jay, for that. Sobrang dami information that they can learn from you.
Feeling ko bitin pa siya eh, it's
I think it's
well,
more
I'm really to be honest, I'm unprepared because I was kind of confused of the time. I was thinking na tomorrow pa yun siya. So siguro naisip ko lang mag-prepare ako ngayon, like siguro slides or something like that, pero well, this is my kumbaga lang to. Even the hallmark sign of ARDS I forgot, but definitely it's hypoxemia. All right. I'm sorry, guys.
From May and here, J, refractory hypoxemia.
Yeah, very good. Thank you. That's refractory hypoxemia. That's good. Thank you. Refractory. When you say like refractory in medicine, refractory is even if you give management, the patient is still having that complication. Patient is still having hypoxemia. Thank you for that. I cannot do it alone, right? So
it's possible to have increased lactic acid but not sepsis.
Oh yeah, for sure. You can have increased lactic acid but not necessarily sepsis, like I said earlier. All right, so you can have increased lactic acid but not necessarily sepsis. Okay, for example, even if you're going to gym, you can have increased lactic acid because your muscles produces lactic acid once your muscles are deprived of oxygen, but it doesn't. Even in your SIRS, look at the SIRS, it's just the screening tool. even if you go to the gym, for example, you have increasing heart rate, you have increasing respiratory rate. So does that mean if you go to the gym, you can have sepsis? The same way as in the context of your lactic acid, right? So any questions, guys?
Thanking as well. Thank you. So helpful for me who is out of nursing field for more than 10 years. Thank you. So refreshing.
Oh yeah, so ano pa talaga, critical care pa talaga ang ano, no? Yeah, minention ko, no? But anyway, so thank you guys. Thank you, Mr. John Mark, Miss Chris.
Thank you
Gracie,
to all
hindi ko na
our
mention lahat.
Ang dami nila. They're more than 200.
Oh yeah. Thank you guys. Thank you for coming today. And of course, I'm not gonna leave you without my motivation. I always do that to my students, guys. Well, NCLEX is it's not difficult. It's challenging, right? I would say like it's challenging. But I would like you to say that not any challenge in our lives na hindi natin nalampasan, right? So any challenge na nandyan sa atin, sa buhay natin, especially this NCLEX, well, we can do it. It's very doable po. It's very doable. You do your part, you do the necessary things. You have to have the ingredients in passing the NCLEX. And of course, most importantly, the faith to God. Kasi everything is useless without your faith. Kasi, even if you're like a cum laude, even if you're the knowledgeable individual from way back in college, top 1 ka man or hindi. I've seen a lot of people, I've seen a lot of top-notchers who fail, who are unsuccessful in NCLEX. I don't know for what reason. But I could say na ibig sabihin yan, so, one ingredient is too many for NCLEX. Ibig sabihin, every ingredient is very vital to NCLEX in order for you to pass it. The question is, how would you do it? Okay? Pwede kang mag-self-review, pwede kang mag-review center, because review centers, I'm not saying that you go, you come with us. You can go with other review centers because review centers helps you a lot in organizing your preparation in your NCLEX. Okay? So, but I would at least say na in IPASS NCLEX, we have a good mentoring department. It's not really purely for education. It will really mentor you in terms of your preparation, especially anxiety management. Okay? We may not have the best motivators. We may not have the psychologists or psychiatrists that that prepares you in your mental state. But at least we have some group of people that can help you prepare your NCLEX in terms of at least decreasing your anxiety before taking your exam. And we see that it's really helpful for them. Okay, you cannot see that from other. I'm sorry, I'm bragging, but you cannot see that from other programs. But like I said, review centers are very important in terms of preparation. You can also do self-review as long as you have the right material, you have the right information. Kasi hindi pwedeng madami, hindi pwedeng konti. It has to be optimum level of your information. It has to be optimum number of your references. Hindi pwedeng lahat po ng references. In other words, baka ma-mess up yung preparation ninyo, guys. Okay? So, ganun lang po. Any questions? Any questions, guys? Thank you, Ms. Mayan. I think wala nang questions, no?
Words of gratitude. Thank you very much as well, guys. So Sir Jay is one of our expert NCLEX educators in our IPASS NCLEX Online Review and Mentoring Academy. So if you guys want to know about our details, let me share to you my screen. This will stop, continue. Yes, I will share to you what do we have in our review program in IPASS Online Review, so that you will also have this information if you might be interested. So our review program will be offered in a 3-month duration. So whenever you are going to enroll in our review program, that's your enrollment will be valid for 1 year. And the entire duration of the program will run for 3 years. So you have 1 year unlimited access. For our live discussion via Zoom, it will be like this. It will be delivered by our educators via Zoom. And if ever that you are not available during the time that they are going to discuss a certain topic, then you can just log into our online learning portal. And we have also 268 hours of discussion. So what do we have? What benefits you can get from our online review is that it's online. It means to say that you can do the review anytime, anywhere, and you can access our program as well conveniently because it's online. There's a live classes, and if ever that you're not available, then you can access our online learning platform. So our handouts are, you can print our handouts. It's downloadable via our portal. And also the very recommended roadmap to NCLEX, guys, this is being given to our students. And they're saying that it's really good. It's a very highly recommended, and it's they find it very useful. So you can study anytime, anywhere. So if you are already a client of IPASS Processing, then you have a discount for our NCLEX review program. And also, in addition to the processing discount, you also have your discount for your UWorld subscription if you are a student of IPASS Processing. So these are our topics that we are discussing in our online review program. So this will be delivered in a 3-month duration program. So you have all the topics that you need for you to be fully prepared on your NCLEX examination. And we also have our expert success coaches. And they have this pre-assessment, progress checking, pre-examination consultation, and post-assessment consultation as well. We also have additional activities like the wellness program, anxiety management program, because we know for sure that NCLEX will cause a lot of anxiety. We have experienced it ourselves because we were able to sit for the NCLEX, and when you're going to sit for the NCLEX, like you don't really sometimes understand the feelings because it's giving you so much butterflies in your stomach. So one of the things that we have added as well is one of the things that our coaches are doing is to do this anxiety management program, and we also have our open forum for our students. And our 5th cycle will be until March 19. So you don't need to wait for you to enroll, but like after the end of March 19, you can actually join our program anytime. So you can join our program anytime if you want already to enroll, if you're interested of enrolling to our program. So if ever that you are not yet a client of IPASS Processing, so for the enrollment, you will be paying 10,000, and you're going to pay or settle the remaining balance of 10,000 after a month. But if you're already a client of IPASS Processing, for your NCLEX processing, so you have a discount as well. So you can communicate with us so that you can already enroll for this. So these are our passers. So in 2021, we're able to have 105 NCLEX passers, and we are so proud of them. A lot of them are US RNs. A lot of them also we have passers who sat for NCLEX Australia. And also we have our review program for the Middle East as well. So these are our instructors. Sir Jay is currently in the USA, and Ma'am Rosanna as well is in the USA. Sir Ryan is here in the Philippines, and Ms. Haya is already in the USA. And we have our coaches and our coordinators. So Ms. Jamie is in the USA, Ma'am Vanessa is here in the Philippines, as well as Sir Mark. And Sir Jen is in UK. So if ever that you need someone to talk to, our coaches can be with you so that they can really assist you and guide you until you'll be able to sit for your NCLEX. So guys, so thank you very much for your time, and thank you very much to Sir Jay for providing us the very, very, very meaty discussion today. And I know that our students learn a lot from this discussion. By the way, let me just share this one, that we also have our review program for the Middle East program. So for our Middle East program, this is a 2-month duration, and it's a 6-month unlimited access as well for our Middle East program. So it's the same benefits that you can get for your NCLEX online review program. But we have different set of instructors for our Middle East online review program. It's not combined with the NCLEX review program that we have. So here are your concepts for the Middle East review program. What do we have will be for the nurses. We don't cater yet for other medical professionals on their Middle East online review program. So this program will be used for Abu Dhabi, Saudi, Qatar, Oman, if ever you are preparing and if ever you are a nurse who's preparing for that examination. The same thing, we also have our success coach for our Middle East program, and our program will be until February 27, and it will start again for another cycle. So for the enrollment of our Middle East program, the 6,400 for the initial enrollment fee, and the remaining balance of 6,400 will be paid after a month as well. So here are our educators. We have our question developer as well, because apart from the concept that our students can get for the NCLEX and the Middle East program, they also have their free practice questions in our program. So guys, so thank you very much for your time. And do you have any questions probably for those who are telling us about the delays on the response? There's a really huge amount of, increase the volume of inquiries as of this time, because like every nurse who wants to go to the USA and wants to apply for their NCLEX, and we are really keeping up, but we are rest assured that we are doing really our very, very best to assist you on your application. So guys, maraming salamat po, and God bless po sa lahat. See you around on the next discussions. I think by Friday or by Saturday, let me check my calendar. By Friday, there will be a free discussion on the IELTS for those as well. For those who are preparing for their IELTS as part of their visa screen requirements, there will be also live discussion here in IPASS Processing sa Facebook page. So maraming salamat po. Any last words, Jay?
Oh, any message? May nag-question pa dito eh.
Okay.
May question, pwede ko bang sagutin to?
Sure.
Can you explain a little why neurogenic shock is the only shock with a sign of Brady? Like I said earlier, let me look. Tingnan natin, wag nating iwanan yung mga questions na hanging, you know. So let's take a look at this one. So, like I said, neurogenic shock is loss of sympathetic tone. All right? If it loses sympathetic tone, it loses the innervation to your blood vessel, which causes decrease in your blood pressure. In the same way, it also loses innervation to your heart. The innervation to your heart, the effect is low heart rate. Okay? Loss of sympathetic tone causes low in your heart rate. That's why it's bradycardia. Normally it has to be increased in your heart rate when you innervate your heart. However, this is already loss of sympathetic tone in your blood vessel, including your heart, which causes decrease in your heart rate and decrease in your blood pressure. All right. So did I answer it right, Miss Sai, Mr. Sai? Okay. So I guess yeah. Thank you for coming, huh? And like I said, NCLEX is very doable as long as you all have the ingredients in passing in the preparation, and you will pass the NCLEX. And success is very near. All right, it's just a matter of time. Mabilis po ang araw natin. So don't wait for the NGN to come out next year for you to take your examination. As soon as possible, take na kayo kaagad, because in the next generation NCLEX, it's gonna be difficult. You know, the format is more difficult than we used to have in your NCLEX. It has been many years that they did not change the NCLEX format. This time, they're going to change it next year, April 2023. It means to say there's no way that they're going to make it as easier. The only way is to make it more difficult, because our standards are increasing as well. So better take it as soon as possible. Better, process your NCLEX as soon as possible. And I will leave you with this. I said this before. Of course, this is our American dream. This is our dream to practice nursing in the US or in Australia or in Canada. Well, this is our dream, huh? This is our dream. The best way to predict your future, your dream is, to predict it is to what? To create it. You have to create your future. How do you create it? Prepare for your NCLEX so that you'll come here, in the US, in Australia, or in Canada. Again, the best way to predict your future is what? To create it. That's according to Abraham Lincoln, guys, if you happen to know. And have faith lang, have faith. And of course, we have to mix it with our faith kay God kasi yun naman talaga ang pinaka-importante. All right, and again, it's a matter of time. See you here in the US. Okay, see you here in the US. Let's meet here. And I'm really glad that I was able to share, the topic. This is just one topic. This is a very little topic on our NCLEX, online academy. All right, I'm doing, the neuro. I'm doing the cardio. I'm doing the critical care. I'm doing the respiratory. And the rest of the IPASS educators are also doing their, their chunks, big chunks actually. Everything is like a big chunk in NCLEX, all right? Not just cardio. Okay, so you don't just study cardio, you study everything. Even if your strength is cardio, it doesn't mean that you don't study cardio as well. You only focus on your weakness. No, it's not. You have to focus on everything, all right? It seemed kind of difficult, but again, like I said, it's doable. All right, so hope to see you guys. And God bless everyone. God bless and take care. Okay, so thank you for coming today.
Maraming salamat po.
Hope you've learned something today. Yeah.
See you next time sa next discussions po natin.
Yeah.
God bless. Maraming salamat. Thank you.
Thank you.
Okay. Thank you very much.